So in regard to dental implants, we want to talk today because lots of questions about the cost of dental implants, what affects the cost of dental implants. And you've outlined that there's 8 to 10 things that affect the cost. So I want to go one by one and make this very informative for whoever's watching this. But first, you are an oral surgeon. And I guess just about any general dentist, somebody that takes a 3-day course could start doing dental implant dentistry. Can you tell me why, and I know there's qualified general dentists and you want to be positive about it, but why would you want to pick an oral surgeon? And how does your training greatly differ from a general dentist? And why
Sure.
implant dentists in particular going to an oral surgeon?
Well, oral maxillofacial surgeons go to an additional 4 to 6 years of training beyond dental school, Randy. So you're talking about almost double or more the amount of training that most general practitioners receive. And, you know, I think there's a certain level of experience and knowledge that comes with that that's hard to ignore. That's not to say, like you said earlier, there's not some competent practitioners in the general practice arena, but certainly when you look at the volume of experience and the quality of experience gained, when you talk about oral maxillofacial surgery training and the formal residency programs we go through, it's just not really comparable to a weekend course or something like that.
Now, help me understand, and I'd like you to talk a little bit about, as an oral and maxillofacial surgeon, you're used to working and rebuilding faces and working in the bone, which is these implants go into. Tell me about your training when it comes to this.
That's correct. Yeah, and my training specifically, and like most of my peers and colleagues in my specialty, you know, in our residency programs, we're doing things like facial trauma and reconstruction. And that can be reconstructing defects that are due to cancers or pathologies or from car accidents or gunshot wounds and things of that nature. So it can be pretty extensive. And you're talking about not only working with bone, but soft tissue defects as well. And so we just have a lot of experience in that arena. And when you apply that then to, you know, augmentation that's sometimes necessary. When I say augmentation, I'm talking about bone grafting for dental implants, to get volumes at sites where there's deficiencies, where teeth have been missing for a period of time. Oftentimes those defects are very comparable to a defect that occurs from a trauma or a tumor resection. So that crossover, that experience is very valuable.
Okay, good. And as you pointed out to me, because I had you on the program, that it doesn't cost more to go to an oral surgeon. It should cost less because you're getting it done right, hopefully the first time. Is there truth to that?
Yeah, I think, you know, and I don't know, honestly, because I don't look at the fees of my general dental colleagues. So it's an interesting misnomer, and I'm not sure exactly where it got started or how that came to be. I think it's maybe used sometimes more as a marketing tool of those providers as a way to keep procedures in their chair, to be blunt. But the reality is that, yeah, we have... there's something to be said, of course, the value up front and the time value of money of not having to do things multiple times and having a decreased failure rate certainly is part of it. But I think just when you look at a dollar for dollar cost comparison, I don't know that there's a huge difference. And when you look at the technology that we're utilizing with guided procedures and in-house printing of temporaries and photogrammetry and all these avenues that we use routinely in our scope of practice in our office, I think the value is overwhelmingly in our favor.
Okay, good. So I have the list in front of me, and we'll go one by one. What affects the cost? So one of them is the type of implant. I guess there's hundreds of types of dental implants.
Correct. Yeah, more than I could even probably recite for you on your program here. There's all kinds of manufacturers that have sprung up, and everybody trying to make some money in this market where, as you know, there's huge demand, which is great, but demand doesn't always overcome research. And so in our practice, we only use several reputable brands that have been on the market for decades and are well researched. They have good funding behind them, and so, of course, there's a cost differential with those type of implants versus maybe what some people call a knockoff, but what these companies call compatible. They'll call it compatible with a system that maybe a dental provider is familiar with, and they have instrumentation for in their office. So the way they sell it to that individual is they say, well, look, you can buy our implant for 1/5 the cost of that branded implant that you've been paying for, and you can still use all your same armamentarium and instruments, and it'll work fine for you, and it'll save you that overhead. But the reality is that the engineering tolerances between the quote-unquote compatible implant and the well-researched, quality-controlled, branded implant that has all that support behind it and research over all these years is not the same.
Okay. Now the other thing is, for somebody watching this, we're only talking about $60, $100 more per implant to get the right implant. Is that true? In many cases?
As a general rule, that's true, yeah. But it can be
so like $100 more per implant to get it done right. Because I think people think it's in the thousands. So doctors, just to save $60 or $100, may choose an inexpensive implant. Is that true? Does that happen?
Yeah, that's true. Okay. Yeah, but, for that practice, it may add up to, depending on what kind of volume they're doing on a yearly basis, that it can add up to, tens of thousands of dollars in their pocket, right, that they save on their overhead. So that's their incentive. But what they're passing on to the patient really isn't a huge savings.
So insurance. And we've talked, you said you get a lot of questions about what will insurance cover. So what is, for a full arch of upper and lower teeth, I guess there's Medicare, Medicaid, even the best dental insurance like a PPO, what's covered?
Well, to be blunt, not a lot. Dental insurance offers patients typically a yearly maximum benefit of $1,000 to $2,000 a year, depending on their plan. There may be some benefits for the upfront cost of an extraction or something that I do on the surgery side of the equation. And there may be some coverage for the crown that their dentist places after the implant is in. But in the in-between, there's not a lot of coverage. And when you talk about Medicare, Medicaid, and government-run plans, there really is no benefits in that arena at all.
So, but you say people finance this. Is that right?
Yeah.
Is that common?
Very common, and we have a number of options that work very well, and people will routinely utilize those.
Now, I read an article that with these dental lenders, that they'll even accept cosigners. Is that correct?
That is correct.
Okay, good. So we got insurance. Now, I guess there's two types of teeth. Because look, when you Google, like I do, I'm Googling how much are implants, prepping for this interview, I'm seeing a huge variety of prices. And I guess some, as you've explained, are snap-in teeth, they're snap-in dentures, and then some are a full arch of upper and lower teeth that don't come out. So what's the difference, and what should we know about that?
Well, the difference can depend on what ultimately the patient's looking for. So what you call a snap-in, or what we call an implant retained denture, can certainly operate sometimes on fewer implants than a stays in all the time or a fixed prosthetic. So it can be, at least up front, it can seem a little more affordable, but it will come with some disadvantages as well.
What are they?
One being that it does have to be removed to be cleaned, and the patient has to do that labor themselves at home. The other is that sometimes those fixtures or the restorations, dentures that go on them can rock or tilt because of the fewer number of implants utilized. So there's some movement even during function or eating.
So is there out-of-pocket expense for the patient to repair these a lot?
It's not so much repair as I call maintenance. So the attachments on those, because of the movement, wear out. And sometimes as frequently as every 6 months, they have to be replaced. And there is out-of-patient maintenance cost that is probably a little bit greater than the fixed prosthetics.
So for a little bit more, the full arch of teeth that don't come on. How many implants, like on the lower, and how many implants on the upper to get teeth that don't come out?
It can be done with as few as 4 implants per arch. And again, some of that depends on patient anatomy, how many teeth are being placed on that prosthesis, and what kind of distance we can get between the front and the back implants is really what determines how many we're going to use.
Now, go ahead. I'm sorry.
I was just saying, but when you look at the value, when you can do a full arch, typically molar to molar, meaning first molar to first molar all the way around on as few as 4 implants, it really is an incredible value compared to replacing tooth for tooth
Would you recommend then to the right patient that they go spend a little bit more and get the teeth that don't come out?
I would, and again, I think you have to evaluate based on the circumstance. That matters somewhat. I think both are good options, but when possible, I absolutely would push patients or recommend the full arch fixed approach. I think most people are happier with that.
You mentioned earlier this term photogrammetry. I guess it's a way to help you with extreme precision place the implants in the right place, and I guess by doing that, it lasts longer. Like it can last somebody's lifetime. Is that correct?
Well, that may be a little bit of an oversimplification. I think that's certainly not incorrect. But what photogrammetry really does is it translates for the lab the position of the implants that we've placed. It translates without any inaccuracy to the computer-generated model of the patient that the lab is using to make teeth. So it allows those teeth to be fabricated very precisely and placed right on those implants the same day we do the surgery, without a lot of in-the-mouth processing or extra steps or procedures that can be uncomfortable to a patient who's just undergone a big implant surgery.
Is it fair to say that most general dentists that aren't oral surgeons aren't using that technology?
I think that's fair to say.
Okay. Now, what about the materials of the teeth? Because I was talking to this when I wanted you on the program, because we're Googling, and I'm here in California, and they're using temporary teeth for advertising purposes, where you think you're getting a brand new set of teeth for around $13,900, $14,000 for a full arch of teeth that don't come out. I guess that part's true, but you explained to me that those are what you're using as temporary teeth. Can you elaborate on that?
Right. So I think the tooth in the day marketing movement, I think, is how most people would refer to that, where you have implant centers springing up that are corporate owned, operated implant centers, and patients go in, they're given kind of this fixed global cost, and they're told they'll get all their teeth out. They'll get 4 dental implants, and they'll get a set of teeth, and they'll get it all in a day. And while in essence that may be somewhat true, in other words, they're getting teeth that day, but what they're not telling them is it's not the final teeth. These are usually an acrylic, temporary, or what we would call a conversion prosthesis. And we use that term conversion because it's just converting the patient from the surgery phase to the healing phase. And then once everything's healed, they have to get final teeth. And there's cost to those final teeth.
And I don't want to put words in your mouth, but do you find it a bit misleading if they're making it look like you're getting a full set of teeth that don't come out and they're really just the temporary teeth?
Yeah, I do. I mean, oftentimes in those ads, they're showing people that are obviously well beyond surgery, that are completely have completed treatment or in their final teeth. They're enjoying life. They've got great smiles, and they correctly are portraying the fact that these prosthetics are beautiful. They're gorgeous, but they're really not showing all the steps to get from point A to point B. And it certainly doesn't happen in a day.
All right. And then they charge you even more, like another $15,000 or $16,000 to get those, as you, I guess, are using zirconia teeth.
Correct.
And so so it ends up more by doing it that way. Interesting. Now, surgery. I guess some people need more surgery. Some people need bone grafting. Some people need extraction. Some people come in, I guess, as denture wearers with no teeth. And so that affects the cost. Is that correct?
That's correct. And and in some instances, there will be anatomic factors that prohibit, or metabolic factors, meaning the health of the patient, that prohibit them from having these kinds of treatments. And that's why I think you need a practitioner that isn't solely financially motivated, that is assessing each patient relative to their needs and making the decision that's ultimately best for that patient and presenting the options that are most viable for them.
Okay. Now, for patients, because I guess you're about 99%, or I'm saying 99%, but 80+% or more of your patients, you work with all the surrounding general dentists. And help me understand this. So they help with the maintenance afterwards. They help create the smile with you, and you work as like a team approach. Is that correct?
That's correct. So our typical team, when we provide care to these type of patients, is myself, the general dentist, or who we call the restorative provider, and then a lab partner. And those are the three critical components of the team. So the patient needs somebody that can do the surgery, lay the foundation, which is where I come in. But the restorative provider is really an equal essential partner in all of this, along with the lab provider who does the lab work and is the kind of the interface between the mechanics of the fake teeth or the dental prosthetics that go in and the dentist who's placing them. So they work hand in hand to create those teeth, because you're talking about not just something that should look good when you smile, but you've got to be able to eat and talk and chew and do all these things with it. And that's where dentists really excel, in relating patients' tooth position and lip position and all of those things that are so crucial when those teeth are fabricated, that they're done the right way. So we prefer to work with those providers who are in our community. They're not going anywhere. They're servicing people here in Central Illinois, and then they follow up with those patients for the necessary maintenance, which is typically just once yearly and very routine. But at least that way, they're not just getting pushed out the door of our facility with no follow-up care and the services that they need.
Now, look, in medicine, if somebody's considering a surgery, and all surgery is a scary thing for any patient, right? The goal is to minimize risk. And that's why, look, I try not to side with anybody, but I think that if it were my own family member, and I've been interviewing doctors with dental implant physicians or physicians and dental implant doctors for many years, and I would say that you minimize your risk by going to an oral surgeon. Do you agree with that? Do you feel that way?
Well, I certainly hope so. I think because of our training and background, we have the most expertise and qualifications, and we have facilities. And when you talk about surgery, and specifically, when most people think surgery, they think anesthesia, as they should. We utilize anesthesia to do these longer procedures, meaning the patient's asleep, they're comfortably unaware of these things that are going on. But our anesthesia training and the facilities, the way they're equipped with, we have full-time nursing staff, we have crash carts and all the armamentarium to intervene, just as any outpatient surgery center or hospital would if there was any kind of medical emergency. So all of those essentials are on hand and here, and we provide those. And I think when you look at dentistry, oral maxillofacial surgery is kind of renowned for that specifically.
What about IV sedation for those afraid of anesthesia or don't respond well? Is that open to them?
Right.
Numbed up and IV sedation?
That's typically the type of anesthesia that we would prefer or typically utilize for these procedures. It is intravenous, but patients are very, very comfortable. And we're able to titrate the medications that we use, meaning adjust the dosings throughout that procedure so that we can lighten the patient up when we need to check the bite and do certain things that are essential to the protocol for the full arch protocols, meaning replacement of all the teeth, or we can then increase the depth of that anesthesia and have them comfortably unaware while we do some of the more invasive things like the extractions, the smoothing or leveling of the bone, and the drilling for the implants. The patient can be unaware while those things are going on.
Now, so I'm clear, and we're going to, probably my last question here, but that it's a one-fee process, meaning even though that you're partnering up with the lab, the general dentist, and the surgeon, it's one fee. Is that correct?
That's correct.
And then that one fee is delivered to them usually when? On the day of the consult? How soon before you can give them that fee?
Yes, typically the day of the consult or shortly thereafter, within 24 to 48 hours, that treatment estimate. So the bottom line is before the patient commits to or begins any care, all of that is spelled out, and they have a chance to review and accept or ask questions and move forward.
So it's not one fee, like for example, here in California, bone grafting has a fee, sedation has a fee, lots of different fees, right? With your office, is it really one fee? that includes
It's really
those
one
things?
fee. I mean, we can break out. It includes all of those things that you're talking about, and they can be broken out if the patient would like to see them. But it's all one fee.
Okay, good. So I guess when a patient calls your practice, which is very common according to you, that when they call your practice and say and tell your front desk, I just want to know how much it is before I go over there. It's not that simple?
It's not that simple. We have to, I mean, because again, it's patient-specific derived care. So we've got to be able to review that specific patient's needs. We have to be able to get imaging and see, first and foremost, are they a candidate for treatment? What does the bony anatomy of the facial skeleton allow for in their case? What will be optimal? We have to look at things like the type of bite that they have. And so those are all things that determine how we proceed, and if we have to do adjunctive or special procedures on top of what would be the normal kind of baseline protocol.
Okay. So if they call, I guess there is a catch. They just have to come in and get evaluated. Is that right?
And we have a process for that that's actually very smooth. We have a couple of very smart, well-trained implant coordinators who have been with me for many years, both on the clinical side. So they've been assisting as technicians in surgical procedures and have now transitioned to more of the clerical and outreach side. And they understand the procedures, the materials very well, but they'll bring these patients in. They'll acquire imaging, photographs where necessary, review their medical history. That then gives us data for our doctors to review and come up with very accurate, tailored treatment plans and pricing for those patients.
Okay, good. Well, Dr. Schroeder, thanks for coming on the program.
You bet. Thanks for having me.